Happy Saturday, right? It's Saturday. I hope that you guys are doing amazing, amazing. And I'm really pumped to be chatting today with Dr. Aimee. And she calls herself the Egg Whisperer. She teaches and talks a lot about fertility awareness and just learning about your fertility so that you can make sure that, down the line, you're not like, oh my gosh, I wish that I, had known that eggs or anything like that. But I'll let her get into it. And I have a bunch of questions that people submitted already. So we can get into that. But
Hi,
hi,
Jenna. How are you?
I'm good. How are you?
I'm doing good.
Good, good. So I'll let you give a little background of who you are and all that good stuff.
Yeah, for sure. My name is Dr. Aimee, and I'm a fertility doctor in the San Francisco Bay Area. And I just love helping anyone who needs my help, no matter where you are in the world. People can find out more about me by going to my website, draimee.org. I just joke it's Draimee. I feel like a rap star because of all the mnemonics we use in fertility, like IVF to the AMH to the FSH. So, I have, an Egg Whisperer school where people can take courses. You can also get your levels checked through eggwhisperer.com. But I just want my message of hope and also fertility to be something that people learn about when they're young before it's too late.
Yeah, yeah. And I think that it's hard because when you're in your early 20s, the last thing you're trying not to get pregnant.
Right.
You
Right.
don't want to get pregnant. And then I feel like a lot people are getting married later and later these days, at least, metropolitan areas. And then you're like, oh shoot, I have, crappy eggs left or
Right.
issues that I could have done something about ahead of
Right.
time. So how early is too early, if there is such a thing as too early to kind of see how things are going with ovaries?
Yeah, I think that these are conversations mothers should be having with their children. If they had problems getting pregnant, miscarriages, fibroid surgery, endometriosis, they should be telling their daughters so that by the time they're even 21, they should get their levels checked. If you are a woman who's 40 who went into menopause when you're 35 and you have a daughter, she should know that. She
Mhm.
shouldn't be finding that out when she comes into my office at 32 and then finding out that it might already be too late for her. So first of all, this conversation should start very early on. So I advocate for getting your levels checked even by the age of 21 for people who, let's say, their mothers conceived them through IVF. But for everyone, I feel like between 20 and 25, you're going to the doctor for your pap smear for the first time during that time. That's also a really good time to get your hormone levels checked. And I also think if someone's putting you on a birth control pill, that's also another opportunity for you to get your AMH level checked. So there are all these time points where we're having these interactions with doctors talking about, like you said, to prevent pregnancy. But I feel like it's also an opportunity to learn about your future pregnancy potential as well. So that's my big thing is by the time you're 25, at least, get that level checked, learn about what's going on about your body. Even if you don't think you may want to have kids in the future, at least you know that information about yourself. And then
Right.
I have all sorts of other little golden rules that I have too.
Well, you have on your website a fertility awareness panel that you offer that people can.
Mhm.
Yeah. So what does that involve?
Yeah, so it's basically the hormones FSH, estradiol, done 2 days after your period starts. So that's called cycle day 3. And then the AMH level, which is the hormone that you can do anytime in your cycle. So if people are on birth control pills or they have the IUD and they're not having regular cycles, it's okay. And that hormone also tells us, like, how many eggs you have left, so to speak. So those are the 3 tests you can have done.
Got it. And so anybody anywhere in the world can get that done. Like you can write a script or and then
Yeah,
or
not necessarily anywhere in the world. I can guide you anywhere in the world, but in the US, certainly, with Quest Diagnostics, LabCorp, all of those labs that are, just basically in every single state. In other countries, I can teach people what to do and where to go and what to ask for.
and you also
Yeah.
then review those panels for people and then can kind of guide them on it even if they're not your fertility patient, right?
Absolutely. I love talking to people about their fertility, their goals, talking about relationships and their career and what they always wanted since they were little. That's kind of my thing. And then I'll tell them what their levels mean to me. And I always tell people what I would do if it were me,
Yeah.
because this is what I live, breathe, and think about every single day. And I'm that person that, if there's someone that needs my help, I want to help them.
Yeah. I mean, I think that you know, and I've talked to a bunch of fertility doctors, and I said, I think that like you have to be a certain type of person to go into this
Right.
specific niched field of medicine because you're a lot of times people are coming to you broken already. You know, they've been trying for years and years. You know, my audience is different. Most of us here are gay or, you know, lesbians who are like, hey, we just need sperm and then we're good. But it turns out like a lot of times that's not true. It was not true for us. Um,
Right.
you know, so even if you are, you know, a member of the LGBTQI community, it is good to get things checked. And I did speak to another doctor about fertility preservation, especially pre-transition.
Right.
So, you know, that's something important to talk about as well. But we have a bunch of questions. If
Yeah.
those, or do you have anything else that you want to add that
Oh no, hit me. I love the questions.
let's go for it. Okay. So we have people that were saying, like, how quickly does your quality and your reserve decrease? She said, I'm 29 right now. Do you think that my numbers will still be as good at 31?
Yeah, I mean, in general, the answer is yes. Your numbers should be just as good. Between 29 and 31, you know, if you look at the graphs, they're pretty flat. However, 39 to 41, different story. Things can change really fast at that age. But I don't want any 29-year-old to think that there's some sort of emergency that they need to freeze their eggs or do something. But get your levels checked, see where you're at, and then, you know, see what's right for you. I usually advocate that people get their eggs frozen by the age of 32 if they're thinking of having two kids and they don't already have one at home. So
Mm,
that's just a little rule to live by, or at least to think about it to see if it's right for you at that time.
got it. Yeah. Who was I talking to before that said, don't plan on the age you'll be for your first kid. Think about the age you'll be for your last,
Yep.
because then that's the age of your eggs. At what point, if we're looking at the, you know, your egg quality starts to, you know, at what point does it kind of start to dip? Is it around that 32, 33?
Yeah, I mean, the thing is, for some people, they're, you know, fertility in general kind of actually starts declining at 25, and that can be kind of scary for people to think about. But that's why, you know, when we think about choosing an egg donor, we actually choose egg donors at around 25 or younger. I know that sounds like what, but that's like the reality, and there's reasons for that. But I think things change really fast after the age of 37, and there, it's not 35. I mean, certainly, you know, as we get older, it gets harder to get pregnant, but the rate of change when it comes to our fertility and the viability of our eggs goes down quite rapidly after 37.
Got it. Okay. All right. And this is all eggs, not uterus, for people that,
Yeah, I mean, your uterus, you know, things can change with your uterus if, let's say, you have endometriosis. I mean, the more periods you have, the worse your endometriosis can get, the larger your fibroids can get, for example. But in general, if you've frozen your eggs at 32 and you're going to use them at 42, your chance of pregnancy is that of a 32-year-old.
yeah,
Unless, of course, you have some of those fertility threatening conditions that can affect implantation, like endometriosis or fibroids.
right, right. But that's the whole benefit of freezing your eggs when you're younger because
Right,
go by the egg age and not
right,
specific age.
right, right.
Crazy weird, like with us. So we did reciprocal IVF. So my wife's eggs
Mhm.
I carried, and I remember when we did the egg retrieval, and then we had our son. We were like, "Whoa, we have like frozen in time babies."
Yeah,
Like I was created in 2016, but I was born in whatever. I mean, they didn't
right.
work, but
Yeah,
you know, it's great. It's weird.
it is. It is.
um, okay, here we go. Um, I'd love to know more about the impact of short cycles on testing and outcome.
Yeah. Short cycles could be a sign. As far as when you're saying short cycle, what I'm thinking of the start of one period to the start of the next.
I would assume.
Yeah. So that tells me there could be an egg quality issue. So
Mm,
getting your hormone levels checked and understanding what's going on is really important, because what starts to happen as our egg reserve starts to go down is our cycles start to get shorter and shorter until they start to actually get longer and longer. We start missing cycles. So that's an early sign that you should pay attention to your egg quality.
I never knew that.
Yeah.
I
Yeah.
only know long cycles because mine have never been regular.
Yeah.
Uh, Dang. Okay, so go get checked.
Yeah.
Here
Yeah, exactly.
we go. Okay, yeah, so somebody said how early is too early. It's not, apparently. I was talking,
No.
you know, I was talking to my fertility doctor today. We become friends and we just chat and I
Yeah.
ask all the questions. I'm like,
Yeah.
and she was saying that, like, look, this has been around for a really long time. Like, children who have to go through chemo and radiation, a lot of times will get an egg retrieval prior to that happening because it can't
Hmm.
affect your fertility. So, you know, you can have 13-year-olds getting egg retrievals. And I said,
Hmm.
well, are your eggs even mature? And she's like, yep, as long as you've
Yeah.
had a period. Like
Yeah.
your eggs, like, and they're like good eggs. um,
Right.
you know,
Right.
so it's never too early. And as she said, like this is just getting the levels checked. It's just a simple blood test that
Right.
you can at least, you know, check the results and just see how it goes. And if it looks good, then the likelihood of you having at least, I guess, declining egg quality is kind of low.
Right.
Like,
Especially if you're young in your 20s.
right. So if it's not clear that
Yeah.
you have PCOS or if you don't know that you have endometriosis or anything, does endometriosis doesn't show up in blood panels, does it?
I wish it did. Unfortunately, it doesn't. I mean, there's that term silent endometriosis, and so many people find out after they've like spent a year trying to get pregnant, and then they go in and find out that it was endometriosis the whole time, or they had a gut feeling it was, and the doctors ignored them for years.
What about
Yeah.
thyroid levels? Because I've heard that thyroid levels can, is that part of a standard testing
I
that,
mean, it's part of mine. I mean, that's the H of the Tushy method. So it's getting your hormone levels checked. And it's not just the FSH, estradiol, AMH, but it's your vitamin D, which is also an important hormone. Your thyroid's an important hormone, your prolactin level. So there are other hormone levels that doctors just like me will check for you. Your OBGYNs will do this as well, usually.
okay.
Yeah, usually.
Maybe. Well, that's
Right.
actually interesting that you say. So somebody had said, how, and I mean, I'm probably going to say get another doctor, but how can we push for more when our RE, reproductive endocrinologist, people who don't know, says we don't need to, you're young.
Yeah, I mean, I call that the pat pat rub rub. Oh, honey, don't worry about that. And I find that really patronizing and offensive. I feel like if you are young and you're having a problem getting pregnant, we need to help you, like, not so much more because everyone will get our love and attention no matter what your age is. But if you're young, there's something that we're missing, and we have to figure out what that is.
Right.
So you just have to use your words and just say, well, thank you for that. Fertility doctors, we're really positive and nice people. We go into this because we have compassion, we're empathetic, we care for people who are going through something that's really, really stressful. But sometimes things come out of our mouths that might make it feel like we're not taking you seriously. Not my mouth. But if you're in that situation, you should just say, well, thank you. I appreciate that. But just to make me feel better,
Right.
just can you just do a full workup for me? I want to make sure I'm not missing something like a translocation or tubal factor or a sperm issue, rather than just saying, oh, just try for a year and then we'll figure out what's going on. That kind of stuff just right. No one says like, oh, just deal with your chest pain for a year and then we'll do an
Right.
EKG.
Right.
Like
Right.
we shouldn't be doing that to fertility patients.
Right. And I don't know exactly, but this person's probably a lesbian, so they're not even trying. It's like
Yeah,
we got to work with you anyway, so just test us. Um,
right,
and
right.
it was probably a man. Like, let's just be honest, that said that.
Okay.
I
Probably.
know,
It's
I don't
probably true. Yeah,
probably.
yeah.
Okay, here we go. Do thyroid levels need to be checked at a certain time of your cycle?
Not necessarily, no. They do not. But sometimes if your TSA is elevated, let's say it comes back at 4.2 and normal range is up to 4, depending on the lab that it's being run with. It could be elevated because you didn't sleep well the night before. That's one of the reasons, or it could just be a lab variation. So I never make a determination about thyroid just based on one level. So if that one level seems to be out of the normal range, then I'll repeat it with a complete panel. And then I have a thyroid specialist that I refer my patients to.
Awesome. Yeah. And then as a follow up to kind of that, somebody had
Mhm.
said, oh, does TSH, which I just learned from you
Yeah.
right now, thyroid, affect fertility? This person said, because I found out that I have a thyroid condition during our IVF journey.
Yeah, so it affects the quality of our ovulations. It can affect how our cycles are regulated. It can also all be connected to our progesterone production. And then in pregnancy, the fetal thyroid relies on maternal thyroid function or actually secretion through the first trimester. So
Mm-hmm.
if mom is not secreting enough thyroid hormone, the baby can then, some studies have shown, depending on how severe it is, deal with issues like lower IQ, and that and that's not something anyone wants to find out after the fact that there was a simple test that you could have done and a simple treatment that could have fixed that. And then sometimes it can also cause miscarriage.
Right.
So those are the really important reasons why we like to make sure that we're doing our very, very best for everyone. And this is just a simple test that you can do, and managing it is pretty simple.
It's also linked to like severe postpartum issues.
Oh yeah, depression absolutely affects our mood. Yeah.
Yeah, my aunt had a really horrible time, and it was because they did not check her thyroid levels. Like, it
Mm-hmm.
could totally been avoided.
Mm-hmm.
Right. Do prenatal vitamins have enough vitamin D, or should I also add more vitamin D?
They actually don't. So most prenatal vitamins have very little vitamin D. They have like 400 IUs. And then if you look at like what the percentages is, like equivalent to 167% of what's required. And I just roll my eyes at that, because the reality is that so many people are vitamin D deficient, and 400 IUs is nowhere near what you would need to maintain your vitamin D at a normal level. And so I have patients where I check their vitamin D. I check it on everybody, and it comes back low. And they're like, I don't understand. I've been on my prenatal for the past 5 years. And I look at the bottle, I'm like, it's like you're barely taking anything. So the key is to take there are prenatal vitamins out there that have more vitamin D, but you just might need to take more. And look at when you're taking your vitamin D during the day. Are you taking it on an empty stomach? Well, that's a time of day that you're not going to absorb it. So you need to take your vitamin D with the meal that has the most fat in it for best absorption. And when people make that change, then they'll see that their vitamin D levels will go up. And the other mistake people make is as soon as their vitamin D is normal, they stop their vitamin D. And it just comes crashing down. It's not one of those things that once you're normal, it stays normal. You have to maintain it. And not, very few people are spending, as much time as they did before outside, unfortunately. But that's the way to deal with that.
Right. Interesting. Did not know that.
Yeah.
Yeah, I learned the other day vitamin D
Yeah.
is.
Yeah, it's a hormone.
Didn't know that.
Yeah.
Yeah, learning so much stuff. Okay. Oh, great question. Is it better to freeze eggs or embryos?
Yeah, it just depends on the person and what their goals are. So if, let's say, you're a lesbian and you want to, have kids in the future, why not make embryos now? Right? And if you have picked the sperm source or you're not sure about it, then maybe freeze eggs. So it just kind of depends on what do you want? What is it going to take? And if you think that you might need your eggs to get pregnant, depending on your age, the age that you're going to be at when you're going to start trying, it might make sense to make embryos. So that's a very personal decision. And I go through the pros and cons with each. So the pros of embryos, what you have frozen, right? So what you have waiting for you in the future. The pros with eggs is that you might change your mind about the sperm source.
Right.
And you might find a known donor that you want to use, and you don't have that person right now. So that might be a reason to just freeze eggs.
Right. And then the follow up to that was, what is the thaw success rate for eggs?
It's really high now. It also depends on the lab. So that's a really good question to ask the fertility doctor that you're working with. So the thaw rate is, the survival rate is almost close to 100% now. And I tell people it's around 97% or better. So if I froze 8 eggs, I'm going to thaw and 8 will survive. And that's pretty typical. In the old days, it wasn't so good, but nowadays it's pretty darn good.
Well, we were one of the very few whose embryo didn't survive the thaw. We shut ready to go. And they're like, no. But we had one more that didn't unfortunately work. But yeah. But I think that one thing to consider that people should think about and consider if you do have a sperm source is that you might have 16 eggs.
Right.
End of it, 3 embryos. One, you know what I mean? That you think, gosh, I have 16 tries to have babies, but you don't understand that all the eggs are not necessarily mature. Freeze for eggs though? Or do they freeze
Say that again? No, they just freeze the mature eggs, only the mature. Very few labs freeze immature eggs.
Okay, got it. So at least, but we go from all the eggs that they can get out. Then from there, it's, okay, which eggs are mature? Then once it's fertilized, it's which ones keep growing and growing and eventually turn into blastocysts. So it really significantly can decline. For us, for example, our second retrieval, my wife had 16 eggs or 19 eggs. 16 fertilized. By day 4, I think we still had 16, only ended up with 3 that turned into blastocysts. So it's like,
Yeah.
so if you can,
Right.
I'm not a doctor, but
Yeah.
my way to do the embryo.
Yeah, I mean, I agree. That's why I say, like, that's the beauty of making embryos. You know what you have waiting for you. Otherwise, you're just thinking about, like, I wonder. And that wondering can be, like, it could be misleading.
Right. And once you have the embryos, at least when they're, frozen as blastocysts, which I'm going to follow up with a different question just for my own personal knowledge after
Yeah.
this.
Yeah.
Then, if you're under like 35, it's like 50% chance of success rate,
Right.
on a transfer if there's no other issues that,
Right.
that are on. So, but again, if you don't, if you're, 25 and you are like, I don't, I'm not even thinking about kids, then cool. Like freeze your eggs. I have friends who actually did 2 rounds of egg retrieval.
Mhm. Mhm.
Um, she was only freezing her eggs because she wasn't partnered yet. And so that was, it was good because ultimately it wasn't, yeah, they dwindle. The amount of
Right.
eggs dwindle when you
Right.
come. So this is my follow-up for my own personal knowledge. So my clinic, and I know that most do transfers and then freeze on day 5,
Mhm.
maybe 6 if it takes a little. But I've heard of clinics doing day 3 transfers. So for people who have no idea what this is, um, you know, I'll give my layman's explanation.
Right.
So once the egg is retrieved, we fertilize it and we watch it grow over a period of time, right? So some clinics I've heard, um, perfect. So where it's
I'll
only
be your Vanna. You talk and I'll point.
amazing. So, some clinics only go on day 3 when it has turned into a couple cells, right? It's not a full blastocyst, yes, which is, there we go. And it's like starting to hatch out of its little shell there. So you know that it's continually growing and growing and growing. Um, why would clinics do a day 3 transfer?
Yeah, so sometimes it has to do with the number of available embryos that the patient might have. So, and every patient has a different priority. So, some patients, their priority is to actually make it to transfer. And you've probably heard because you talked about that IVF pyramid, right? So, you have a certain number of eggs, a certain number of embryos, and then a certain number of blasts. That number continues to go down. So, you share that you guys had 3 blastocysts in the end from the 16 eggs. But some patients might not get any blastocysts, and their priority might have been to actually do a transfer. So let's say you have 1 embryo and you really want to transfer, it might be better to transfer day 3 than let it go to day 5 where you might not have an embryo to transfer. Even though
I was going
the
to say,
likelihood of that embryo even working if it didn't make to day 5 is probably really low. It may not be 0, but it might be close to 0. But that just makes the person feel like they honored what their goals were during their journey.
is it better
So,
the uterus versus the petri
so
dish?
yeah, so again, that's a lab to lab, doctor to doctor, so it's like if there's a clinic out there that says we only transfer day 3s, we don't culture to day 5, what they're saying is we're really good at day 3 transfers, in my opinion.
Hmm.
And transferring and culturing embryos to day 5 is actually really hard work. It involves like special media and a really special skill set on from the embryologist there. So,
Mm.
when I hear those things where people tell me, oh, they only do day 3 transfers here, they don't culture to day 5, that makes me think that they're really, really busy. They have a huge volume and they're just trying to get those embryos in as soon as possible so that maybe they don't, deal with culturing to day 5 and freezing embryos day 5. That's kind of what,
So
those are
it's
the kinds of things that come into in my head.
in your opinion.
Say that
Necessary.
again.
It's not necessarily a great sign in your opinion if they say we only do day 3s.
Yeah, I mean, there's certain clinics that, yeah, I mean, the thing is that sometimes people are limited by what they can do because of where they live. Do you know
Mm.
what I mean? And so I would say that you can't push a clinic who's doing day 3s to do day 5 because that might not be good for your embryos. So
Got
you
it.
have to listen to what they're saying and take advantage of the technology that's there and know the difference and why they're saying what they're saying and then make the right decision as to what's right for you. Because sometimes for some people who would rather not, like, why would I transfer a day 3 embryo? if it's not going to make it to blast, if my goal is to, have as much information about myself as possible. So
Right.
yeah, I don't necessarily know that it's a bad sign. I would say it's a sign that you may not be getting all the options that you might have thought you were getting from the very beginning.
Got it. Okay. That was my own question.
Yeah, yeah.
The more you know, guys.
Right.
Okay. So this answer is, I mean, we can't really necessarily answer, but I think a lot of people probably ask this question of how many embryos do I need if I want to have 2 kids?
Yeah, I mean, so I would say, are there any uterine anomalies? Is there adenomyosis? Is there endometriosis? Is the sperm quality good? Those kinds, the answers to those questions will also help guide me. And then knowing your age
32.
and, so 32 years old, how many embryos if you want 2 kids? Probably, I mean, there's probably a 50% chance that you could accomplish it with the 2 embryos that you have. But I would say comfortably at 32, if you had 4 embryos, that would feel really good.
Yeah.
Because when you go back for a second embryo, the likelihood of you being able to make more at 34 is still really good. So if you have 2 at 32 and you're starting your journey then, and you transfer the first one and it works great and the second one doesn't work, you still have a renewable resource, which are the eggs. However, if you're, let's say, 37, it's a different story, right? Because when you're 39, you may not be able to accomplish the same thing that you did at 37, and you may have a harder time getting another embryo to replace the embryo that didn't work from when you were 37. So at 32, 3 to 4, but you could accomplish it with just the 2.
Right. It's
Yeah.
hard. It's hard to say, but
Right.
with 50% chance, if there's not issues,
Right.
think about that. But
Yeah.
okay, let's see. Are there any supplements that help the embryos make blastocysts if someone has poor egg quality?
Absolutely. I do think there is such a thing. I know doctors sometimes say, oh, there's no science behind that. And I call out, I won't swear here. My husband says I swear too much, so I'm not going to swear here. But yeah, I think that there are. So CoQ10 is one of them. NAD is another one. So I feel like people just go online, they read all this stuff, and then they come to me with these lists of like 30 things that they're on. And I'm like, you don't need 30 things. I tell people you really need just 5 things. So it's a prenatal with vitamin D, fish oil, CoQ10, NAD, and another supplement called pterostilbene. So those are my 5 special things that I call them part of my special sauce that I think that can help with egg quality.
Okay. Do you have like a blog post on that for people, or like
Absolutely. Yeah. You just go to my website, Egg Quality Supplements. It's all there.
All right, cool. Just plug it in my phone here. Okay, great.
Okay.
Yeah. Or I can write it out in the post specifically. Okay, cool. Someone said you are really a legend in the field. Look at that. Look at you.
Maybe I'm related to them. I don't know. That sounds like something my mother
No,
would say.
they're in Pakistan. They're in
Oh,
Pakistan.
that's really sweet. Oh, that's sweet.
So nice.
That
Maybe
is
they
nice.
meant me because I know so much
Probably
about it.
you.
Maybe.
Probably not me. It's not me.
Oh, interesting. I've never heard of this before. What are your thoughts on a dual transfer? One on day 3 and another on day 5. That's their clinic's policy.
Yeah, I don't want to, again, I'm not going to swear, but I'm going to call that out and be like, that's a bunch of bullshit. Yeah, I mean, I'm not going to put a catheter in a uterus twice in 2 days. I mean, that just doesn't seem right to me. By disrupting whatever is going on with that day 3 embryo and going back 2 days later. Am I missing something? Is there something that I don't know and I'm the dumbass? I don't think so. But I mean, whatever I say publicly, I would say to another doctor that's sitting right next to me. That's my rule. So I'll never say anything that I feel like later on I would, regret. And I would say this to you. I would say this to the doctor who's doing that. And I would be like, what the hell are you doing? Why would you do that to somebody? Yeah. And I know that there are people that do that. I mean, I do. And when I hear that story that a patient has gone through that, I question the reasoning behind it. And I would say it makes no sense to me.
Like, why wouldn't you just do 2 on day 5? if like 2 is your, but it's so funny because I know clinics where they will not do 2 at all. They will only transfer 1. So it's so interesting that
Yeah.
What if you don't want twins? Because that was my biggest thing. I'm like, oh, hell no, we're transferring one. I like showed up and they're like, one or two. I'm like, one.
Mhm. Right, right. Yeah. I mean, I think that women, we are pleasers and we want to please our doctors. And it's really funny for me because I get people that message me all over the world and I'm like, why aren't you asking your doctor? And they're like, well, I don't want to upset my doctor. And I'm like, I don't understand that concept. I mean, my patients
Right.
know they're welcome here because questions are allowed. You know, this is the place where you're allowed to ask as many questions as you want
Right.
and you get all your answers before you even leave.
It's not.
And so it just breaks my heart that people are in that situation where they're felt that they're forced to do something where they may not want to, they don't want to do it.
Yeah. And if you're not educated on why
Right.
they're doing that, they're like, oh, this is just our policy. And you're like,
Mm-hmm.
oh, okay. I guess this is what clinics do.
Mm-hmm.
I don't know.
Yeah.
That's weird.
Yeah.
That's weird to me.
Yeah. I agree.
Something shady going on. All right.
Yeah.
Experts said it is shady
Yeah.
too. So, okay. I don't know what this word is, but thoughts on Zymote?
Yeah. Zymo, it's a little, I think I have one right here. Let me find it.
Oh, look at
It's a
that.
little
I'm like,
device.
someone's making up words. What
No,
is it?
it's a real thing. It's a little, it's like a little filter for sperm. So
Looks
you
like a
put it
whistle
in,
condom.
yeah, it does actually. It feels like one too. You put the sperm in one chamber and you take it out of the other after about 30 minutes that it's incubated. And the thought process is that the best swimmers make it to the end. And those are the swimmers that you draw up for the IUI procedure or the ICSI procedure. And so I do use filters on sperm because, you know, for my patients, I want to get it right the first time as far as picking the right sperm cell. And there's, you know, typically millions of sperm cells to pick from.
Right.
So whether it's IUI or IVF, I want to do whatever I can to make the sperm, I use the word sparkle a lot, to make the sperm sparkle for the procedure. So,
Well,
yeah.
so you do that for IUIs.
I use the Zymote for IUIs as
Because
well.
wouldn't the best swimmer just get there anyway?
So not necessarily. I mean, the thing is that when you're doing IUI,
Going into stuff.
um, that you might lose some of the swimmers. You know, I'm just trying to think. Yeah, I mean, I think the goal is to get the best ones to the top, and I'm not sure. You're so cute.
I'm like trying to put my phone in this thing. We get real, guys. We're real at this place.
Yeah, I mean, I guess, you know, putting a whole bunch of bad sperm close to the egg isn't as helpful as putting the best sperm close to the egg.
Got it. Got it. Yeah, we had to do ICSI with our second sperm just wasn't great. But the other vials, we had like 30 million sperm, and I'm like,
Yeah,
one flippin' sperm couldn't find the egg. Like,
I
what is
know.
wrong with you?
I know. I know.
Love
And
our
I
donor,
and
but like,
I use filters even on donor sperm as well. So if someone has frozen sperm, I'll filter the sperm as well with one of these little techniques. I know not all doctors do that.
I've heard of it.
I don't use Zymot for frozen donor sperm though. That's only for if it's a fresh donor.
Got it.
Yeah.
Okay.
There
Got
just
it.
isn't enough sperm that's in the vial for us to do that with.
Got it. Okay. Do. Yeah, somebody shared that they actually, yeah, that they didn't make it, that they all of none of their embryos made it to freeze. So it's kind of, yeah, so it's like you could, I'm so sorry that happened.
Yeah.
Is it required or recommended that I do genetic testing before choosing a donor?
The thing is that you could go sperm shopping first and then see if your donor isn't a carrier for any recessive genes. Just make sure that they did a complete panel. So if they just looked at, let's say, 5 diseases and they're negative, that doesn't necessarily mean much. But if you want, just do a panel like the Sema4 panel or Invitae, one of those. They're usually between 200 to 300 genes. And that way you don't have to wait. Like if you found a donor, you don't need to get tested and wait another 3 weeks to purchase the donor. Do you know what I mean? So for me, I just want to get it done up front. And I just, as soon as I meet a patient, I'm either shipping out a saliva kit or having them come here for a blood draw so that I can get their information ASAP so that I can do, it's just a matching game to make sure that they're genetically compatible with the sperm source.
Yeah. I think it depends on your clinic too. We were required to get genetically tested. It wasn't like anything crazy, but our donor like had nothing and we still needed to like get genetic counseling just because you're using a donor. It's unknown and it's like
Right.
whatever, you know, They just
Yeah.
present you with all the potential
Right.
things that could go wrong.
Right.
Um,
Right.
okay. Someone said, I'm starting IUI next month. Do you have any last minute health tips?
Yeah, I mean, I'll just go back to it's not just health tips, but just making sure you've looked at your tubes and that they're open. You're not wasting your time on buying sperm for IUI where you're just going to spend thousands of dollars and waste months of your life. And then you find out because the doctor just made that assumption. Let's say you're a lesbian, that your tubes can't be blocked. And we know that your tubes could still be blocked even if you're a lesbian. Um, and then the other tip would be, I think right now with COVID, a lot of people are signing up for treatment plans without even having an ultrasound done because
Yes.
those in-person interactions have been minimized. So I always advocate for patients getting seen ahead of their cycle start and getting an ultrasound done. And then as far as health stuff, I mean, I just tell everyone take CoQ10 until you're done having kids. And then maybe incorporate acupuncture if you think that'll help decrease stress. Acupuncture can also help with the symptoms that sometimes the fertility drugs can cause, like feeling moody or nauseous or crampy. You know, acupuncture can help with those symptoms. I'm not sure how much it helps with egg quality, but I feel like if it's going to help decrease stress, it can help with the experience as you're going through it.
Mm-hmm.
And I think eating healthy, you know, being active, you don't need to ride a Peloton 3 times a day, but just moving your body and getting your steps in, getting good sleep, like those are all good tips. And, you know, also finding a mindfulness practice or a mantra that you can repeat and stay with you, especially when you're stressed out, like for the IUI. If you're stressed out and you're super stressed and you're lying there waiting for the doctor and you're scared and they won't allow another person in the room with you, it's important to have a mindfulness practice that you can go to immediately.
That's good. Yeah. And acupuncture been proven to help with IVF, at least like um, I don't know if it helps with implantation, but it helps with
Yeah,
something, they
it
say.
can. Yep, it can relax the uterus. So, you know, a lot of people are told to take Valium, and what some studies have shown that an acupuncture treatment before and after a transfer is as good as taking Valium when it comes to relaxing the uterus. Because when you put a catheter into the uterus is a muscle and it can contract a whole bunch. There have been really cool time-lapse videos that have been done showing a uterus on Valium and a uterus not on Valium, and the difference in the number of contractions of the uterus, contractions of the muscle of the uterus. It's pretty cool to watch. Those are the kinds of things that I like watching.
I'm like, maybe for you.
Maybe for me. Yeah, I know. I know. If it has nothing to do with fertility, I'm not interested.
Oh, okay. Yeah, I did acupuncture before my
Mhm.
transfer and then right after. Um, I don't know, made me feel good at
Yeah.
least to know that I'm
Yeah. I absolutely
controlling
recommend it.
something, like, controlling
Yeah.
what you can. Okay.
Yep.
Um, Somebody said, is there any way to improve getting PGS normal embryos? And then they said they are not mosaic, all aneuploid.
Yeah,
Okay.
absolutely. So,
Yeah. And then are
yeah.
there any supplements that you would recommend as most important for this?
Yeah. So when we're talking about embryo quality, we're talking about it's a simple mnemonic, it's age. Age is your age, your genetics, and your environment. And we have to think of both sources, and that's the egg source and the sperm source. So you have to look at your age and say, is this normal for me at my age? And the answer could be yes. Like if you're 40 years old, it's very normal to have all your embryos be abnormal. And it's just part of like your age has nothing to do with anything that you can control for the most part. However, there are still things that I like to do for my patients, like the egg quality supplements that we talked about a little bit earlier, taking a steroid called HGH even leading up to your cycle and even during your IVF cycle, and incorporating all those mindfulness practices that I think can just help with the journey. But who knows, maybe by decreasing stress and increasing joy, I mean, maybe there's something to to that. I'm not sure, but I really wish that were the case. And
Yeah.
same thing for sperm. So, you know, if let's say you're using a sperm donor, not all sperm donors are the same. So consider switching to a different sperm source. If you're partnered in a heterosexual relationship, pay attention to those same things: age, genetics, and environment. So you can't control your age or genetics. I don't want to flip anyone off. But then there's also the environment, right? So smoking, drinking, weed, you know, body size, like those are the really important things that I talk to people about.
Get a new husband, maybe. I'm just kidding. Maybe.
Yes.
Yeah, maybe. No, I'm just kidding. Um, okay. I want to someone said, okay, I finally had salpingogram. Salpinogram.
Uh-huh.
Okay. I'm like, you probably know what this is. Okay. She said, I'm 34. I've had one ectopic pregnancy, one miscarriage. I only have one tube left. My second tube is open, but scarring in the tubes. Um, Doctor says, try to get pregnant. What are your thoughts? Because she said she's scared.
Yeah, so my approach is always diagnosis before treatment. And so what you're sharing with me is that there's tubal factor infertility, and that means that if your tubes are scarred, it's really hard to get pregnant naturally. So IVF was invented for young women with this problem. So I would go and preserve your embryos, and before you even transfer, I would look at that tube that's remaining. Because when you put an embryo in through IVF, you actually are at higher risk of having an ectopic pregnancy if your fallopian tubes especially are already blocked. So we already know that you had a history of ectopic. So I wouldn't want you to have an ectopic after IVF. So create your embryos first, then go in and perhaps have that one remaining tube removed before you do an embryo transfer. So that would be my recommendation if someone had that situation here with me in my office.
Oh, wow. And is that like laparoscopic surgery?
Yes. Yeah, laparoscopic.
Okay. Someone said, if you're anxious about needles, are there any options with IVF if you want to use your own eggs?
Absolutely. So I have
Really?
patients
I'm like,
who are,
no.
yes, I have patients who are needle phobic, and I do all their mixing for them here. So I'll mix their shots ahead of time, let's say 2 days ahead. So they'll come in for their monitoring appointments, and then I'll mix their shots for them for the next 2 days. And then they get the Buzzy Bee. So the Buzzy Bee is this really cool device. It has a little ice pack and it vibrates. So you put it on your skin before your injection. It numbs the skin, and then you turn it on and it vibrates the skin, and then you put the needle and you don't even feel it. So that's one technique. The other technique is just to come here every day. I mean, I joke with my patients that I practice pain-free gynecology here. But my goal is every single experience for patients to be as pain-free as possible, and that includes, and fear-free, and that includes the injection. So I have patients who literally come here every single day for a shot, and either me or one of my assistants will do it. And that trigger shot, they'll just come. I literally have a chair in my house, and that's my trigger shot chair, where patients will get their trigger shot. They'll just come at whatever time I tell them. They'll come to my house and I'll give them the trigger shot. So I try and make it as easy for people who have that fear of needles.
Wow. This is like,
yeah, but not every clinic has that.
Service. Yeah. Look at this.
Right.
I did my friend's trigger shots actually because I'm like, I'm good. Come on over.
Yeah, exactly. You know what I mean? Exactly.
I got this. I'm a lawyer, doctor.
Yeah.
Okay. Okay. Thoughts on? Okay. Again, I don't know what this means. Shanghai or dual stim?
Yeah. So dual stim just means leaving. So basically, what you're doing is you're doing an egg retrieval, right? So you're taking IVF meds, and then right after the egg retrieval, you go right back on the meds and do a retrieval like 2 weeks later.
Oh.
So I do about 2 or 3 duo stims per month, and these are for patients who are running out of eggs. And what I mean by that is they're at the point in their lives where I don't know when they're going to stop making eggs. So it could be very soon. So I'm getting between 1 to 3 eggs on each side of the egg retrieval. There are clinics that have done it before for patients who have double-digit eggs. I don't do that. And the reason is, if you can imagine having like 14 eggs retrieved and then 2 weeks later going back and getting more, like, I don't know. That just seems like a lot of cramping and a lot of hormones.
Right.
And not something that I would want to put myself through. So I can't do that to somebody else. But yeah, I have a lot of experience with duostim. And there are doctors all over the country and world that do that as well. Our experience as IVF doctors in doing that comes from, let's say, patients who are older for the most part, and then also, let's say, patients who have, let's say, a diagnosis of cancer. We want to get as many eggs out as soon as possible for them. And so that's the type of approach that we'll take.
Got it. And then the follow-up to that was, are I guess probably meant to say eggs from the second retrieval as good as
Oh yeah, it's amazing. It's crazy to think that you can get mature eggs again, like, 10 days after an egg retrieval. And I feel like it's kind of not necessarily revolutionized, but it's made us rethink how we can grow eggs for patients. So we can do random starts, we can do starts, natural cycle starts in the follicular phase, we can do mid-luteal phase starts. So it's a total trip. And when I started reading about these like different approaches like that, I was like, no way, like impossible that you could do this. And then I started doing it and I was like, oh no, this is actually kind of cool. And there's some studies showing that even in women who are over 37, you actually get better quality eggs when you stimulate them in the second half of the cycle. And I think there are certain scenarios and situations where starting stimulation in the second half could be more helpful, like people who make one egg really fast in the very beginning, or people who ovulate really early in their cycle. That's another way of saying the same thing. Sometimes starting after ovulation might be better for them.
Interesting. Well, I heard this crazy thing that you can take parts of the ovary and plant them in your arm.
Yeah. And then grow an egg from there. Yeah.
Yes, if there's like uterine cancer or ovarian, I was like, what?
Yeah.
My doctor told me about that this morning.
Yeah.
Crazy.
Wild. I know.
We were talking about fertility preservation,
right.
Precancerous, clearly.
Yes.
Like, just a Saturday morning chat we were having. Okay. Do you have a couple more minutes?
Oh yeah, totally.
Okay.
I can talk about this all day long, honestly.
People have a whole lot of questions.
Yeah.
Here. Okay. Someone said, I'm anemic. I have low HGB and iron levels. Does it interfere with the success rate of IVF?
Yeah, there are some studies to show that low ferritin levels can decrease fertility rates and implantation rates. And so if you are low in iron and it's not from a genetic form of anemia like thalassemia, you might want to get an iron infusion depending on how low it is so that you can get tanked up as soon as possible before pregnancy. If it's a genetic version of an anemia, I mean, that's just how you were made. And there's no amount of iron that can necessarily or generally help with that.
Okay. Thanks, parents, right?
Yes, exactly.
Okay, can you do something about having follicles growing in different sizes during stim? Medicines, or is there anything natural that can be done?
Yeah, I mean, my technique in a case like that would be to have patients come in a little bit sooner, or earlier in the cycle. So typically patients start medications and they go back into the clinic 5-6 days after their first visit. And I would bring someone in 3 to 4 days after they start stimulation so that if there's a chance that I can catch that, I can actually slow things down with the antagonist medication or titrate the doses so that maybe I'm bringing them down or using a different protocol, like a hybrid protocol, fertility pills combined with shots rather than shots from the very beginning. So there are lots of different things that we can do in cases like that. You can also, let's say, take a shot of the antagonist at the very beginning of the cycle to kind of slow things down a little bit and then ramp up. So there are lots of cool things that you can do to help in cases like that. They don't always help though, because sometimes it might be a sign that the egg quality is low and that there's not much that we can do sometimes in cases where it's really low.
Yeah, but this is why when you're going through a stim cycle, you're there a lot. You're at the doctor like every other day as you're getting close to measure everything. But we had one of the pens, the foul stim.
Yeah.
You make the dose yourself.
Right.
So it's a very adjustable dose.
Right.
That you can just easily do. What are some options available to somebody with high FSH and low AMH that isn't using IVF or donor eggs because of cost?
Yeah, so be as aggressive as you feel comfortable being. So depending on your hormone levels, if you're in a situation where you only have a follicle count of 1, then it doesn't make sense to use medications because medications won't turn the 1 egg into 3 eggs. But if your follicle count is still 2 to 3, even at 2, taking fertility drugs to get both to grow means you get 2 chances in 1 cycle. So I would just take that approach and talk to a doctor who believes in your fertility and has the same hope that you have, that you still have a good egg, and go for it. I've definitely had patients in that kind of situation and we've been successful.
Yeah. And if you go to my website, so connectingrainbows.org, I have a ton of financial resources on there, different grants and loans that you can apply for that can help cover if you need to go through IVF or something like that. There's a lot. Okay. How much milligram of CoQ10 is good to take long term, and when should you stop taking them while trying to get pregnant, either during IVF cycles or in between? Should you stop at a point?
No, I mean, if you're a patient of mine, I tell you to continue, even through your egg retrieval. There's no reason to stop. I mean, if you look at where CoQ10 is sourced, it's basically like having a green leafy vegetable salad. It's not a danger supplement at all. I tell my patients, again, you should talk to your own doctor about what their recommendations are, but depending on the situation, I even tell my patients to continue in pregnancy.
Interesting.
Yeah.
Okay. So the person before with the tube, with the heavy ectopic pregnancy, said that the doctor is still advocating for me to try to get pregnant through the remaining tube. Do you think it's too risky?
I absolutely do. And so that doctor's priority, it sounds like it's different than ours. And that's where you just have to advocate for yourself and say, I appreciate you saying that, but I've been through too much and I'd really like to preserve my fertility, given everything that I've been through, so that I can, just move on and choose a treatment for me that will give me the best chance of having an intrauterine pregnancy. Thank you so much.
And move on to another doctor if that person is.
Exactly.
I'm so sorry. Okay. So this person said, I'm 38. I had 2 chemical pregnancies. PGS yield was normal, no issues, just and she had her tubes tied. PGS yeast. What would you do if I was your patient? So if you had your tubes tied, you gotta have to do IVF, right?
Got it. So I think what she's saying is, I'm not sure if the 2 chemicals were with the PGS embryos. I think maybe that's the clinical challenge that she's facing.
Okay.
That she has her tubes tied, that's her diagnosis. And then she did PGS and transferred both times, and she ended up with biochemical pregnancies both times. So in that situation, I would say, I wonder if the tubes are still causing a problem. So even though your tubes are tied, potentially where they're tied, between where they were tied and the corner of the uterus, you can have fluid that collects there. So that fluid is called a hydrosalpinx. So that portion of tube could be, in a way, leaking inflammatory cells into the uterus, causing biochemical pregnancies. So I'd look really closely at those fallopian tubes, and potentially they're causing a problem. I would do implantation testing like the ERA test and the Receptiva DX test, and talk to your doctor about doing a cavity evaluation like a hysteroscopy, and maybe doing a hysteroscopy laparoscopy at the same time, because that's just a lot to go through.
That's, no. Hysteroscopies are no fun, but actually the second
chemicals suck too.
Oh my God. But that's, that is,
right.
The first hysteroscopy I had, I almost fainted off the table. But the second one I had was totally fine because I had already had a vaginal delivery. And so, they were like, look, you've been pregnant, your uterus has already expanded, you already had that vaginal delivery, and literally it was like nothing, but they had like the salts all lined up. I was like, I'm gonna pass out, guys. It's gonna be bad. Let's be prepared. Okay. This person said, I'm 38. What are my chances with 3-day, I guess, embryos? Quality of grade 3. Only 2 eggs fertilized. The second egg didn't make it to blast.
Yeah. So the grade 3 could mean, depending on the lab, really good quality, or grade 3 could be low quality. Depends on the grading system that's used. In the lab that I work with, grade 1 is the best, grade 3 is the worst. So if we go along, if we use that grading criteria, I would say grade 3 at 38, we're looking at a less than 5% chance of being successful. However, if grade 3 means the best quality in that lab, then I would say you have about a 25% chance of being successful, because each embryo, even though it's grade 3, has about a 25% chance of being genetically normal at the age of 38. So you have 3. I would say 1 out of 3 could be normal. You transfer all 3, we're looking at maybe 30%.
Or triplets,
Or triplets.
You know what? Maybe that wouldn't be a bad thing. What are your thoughts on PRP? And what is that?
PRP, it stands for platelet-rich plasma. It's something that you can isolate through a blood draw. These cells are then injected directly into your ovary, the thought being that they can rejuvenate the eggs. I have seen firsthand that it has worked in getting postmenopausal women's embryos to grow eggs. Oh yeah, firsthand. I had a patient, 47 years old, postmenopausal, FSH over 40, hadn't had a period in a year, had PRP injection, came back to me. We grew 3 eggs. I got 2 eggs out and a blastocyst. It was not normal. It didn't result in a pregnancy. I am yet to see a patient who's done PRP have a successful pregnancy of my patients. It doesn't mean that it's not going to happen. I really want it to happen soon, because you can imagine these are patients who are highly motivated to not use a donated egg. So I want to support people in their journeys and honor what's important to them, and still give them a chance. Even if it's a 1% chance, I feel like it's their right to choose that for themselves. Exactly.
Right.
So that's what PRP is.
Oh, wow. But I do want to say to anybody here who is struggling with that, and maybe because of an egg quality issue, neither of my children are my genetic children. They're my wife's. I carried, and they couldn't be any more my kids. DNA, like I always thought was important to me. Like I thought I always want to have a biological child. I want to be like, oh, they have my eyes. Once that child is in your arms, doesn't matter where they came from. Doesn't matter. Like if we have a third, which I don't know, I'm not even considering using mine, because like however you make your family is perfect. But I honor so much people who really want that biological connection. But I think that the second best thing could be still carrying a pregnancy, whether you use an egg donor or an embryo donation. That it's still going to be amazing. I promise.
It is.
I am proof of that. Okay. What is the dose of HGH that you use on your patients 40 and above?
Yeah, so typically one vial of omnitrope has about 4.5 doses of it if you dilute it and get about 0.25 mLs per dose. So that's the dose that I use twice a week up until when your stim starts. And once your stim starts, I'll either have you dose the same amount every day or every other day. HGH is very expensive. One vial is around $400, so it's no joke. So if you're going to prime with it, you're spending about $800 a month. And then in cycle, you can spend, like $3,000, depending on how much you use and how often. So I don't know that people need to spend that kind of money. I don't know how much it really helps people, but I do think maybe taking a little bit, maybe 2 weeks even before stim starts, if you're 40 or above, or even if you have a high FSH or decreased egg quality. I mean, I even use it in my egg freezing patients. So I've used it in patients who, let's say, are 32, FSH is 14, AMH is 0.3, and they want to freeze eggs. I will use HGH in their protocols. I don't know if it's really helping, but it's at least something that might help.
Got it. Hopefully she understood that, because I have no idea what you just said. Everyone else just ignore that part. Somebody said, I just got my CMV results back and I'm negative. My spouse and I were going to do reciprocal IVF. Is this only possible if my spouse is also negative?
Yeah, so I think CMV is just a really arbitrary test that the FDA requires sperm banks to do on their sperm donors. So I tell my patients to ignore CMV. I don't test my patients for CMV. And I tell them, when you're looking for a sperm donor, don't use CMV as a criteria.
Ours is, we're the opposite. Like we didn't care. I think our guy was positive, and we're not, but he was perfect for us. And I think the likelihood of something going wrong was like, what, 1%? If
it's 0%. It's 0%. If CMV was really a thing, you would actually test your sexual partner if you're in a heterosexual relationship for CMV.
Right. See,
so it's a completely arbitrary test that increased costs for people going through treatment and causes a lot of confusion for absolutely no medical reason. You can't get CMV from sex. You can't get CMV from sperm. You can't get CMV from embryos when you're using CMV positive sperm if you're CMV negative. It's just impossible.
So we're going to get kicked off in a minute and a half, because we're almost at an hour.
Oh, yeah.
I didn't even know that was a thing. Thank you so much for all of this. Oh my gosh. I think this is an interesting last question, but can a patient ovulate early and miss like a retrieval window?
Absolutely. So early ovulation is one of those IVF challenges. So it can be a sign of poor egg quality. It can also be a sign that you didn't start the antagonist soon enough, but there are things that you can do to prevent that.
Okay. All right. Well, everybody just go to your website. Everyone go to your website. We've got you, everyone knows you're here. I'm going to tag you in the thing, and
thank you.
They'll answer all your, hopefully your blog can answer questions. You can work with her. You can do your fertility panel thing, and
Yes.
clearly she knows what she's talking about. She just used a lot of medical terms here. But thank you. This was
You're
awesome.
welcome.
I really
You're
appreciate
very
it.
sweet. Thank
All
you
right.
for doing everything you
Oh,
do.
oh, of
Thanks.
course. All
Bye-bye.
right. Bye,
Bye.
everyone.
Bye, everyone. Bye.
Yeah.